We're going to start again. We're going to start with our last panel of the afternoon, co-organized with the Geneva Health Forum and the Future of Hospitals and Health Systems Initiative. Please allow me to introduce our moderator, Sonia Roschnik, which I think many of you in this room already know, former founding and executive director of the Geneva Sustainability Center, as well as who is part of the International Federation of Hospitals. Sonia is a healthcare sustainability leader known for advancing climate action and championing sustainable leadership. With a strong focus on collaboration, practical solutions, she's really played a key role in developing carbon reduction strategies, supporting organizations to not only assess but also reduce their environmental impact. So this panel on kind of how health can contribute to collective climate action, she's the perfect person to moderate it. So Sonia, the floor is yours, and thank you.
Thank you so much, and welcome back, everybody. It's really great to see you. So we've got the wonderful opportunity here to try and celebrate a little bit about what the health sector brings to this agenda and try and get you motivated into thinking that some of what maybe happens in the health sector is transferable to all sorts of other sectors. And I'm sure that a lot has been learned from the health sector from other parts, but the reverse can happen as well. So I would like to thank the Geneva Health Forum and the Future of Health, Healthy Hospitals and Hospital Systems to be part of this session, because it's really core to the mission, and it's a beginning of the collaboration that needs to exist. So I'd just like to, I'm going to frame the session a little bit, but I'd like to welcome our wonderful panel. First, we've got Valérie d'Acremont, who's responsible for global health and environment at Unisanté in Lausanne. We've got Zeenat Sulaiman, who's online, who is our Chief Executive Officer for Aga Khan Health Service in the region of East Africa, but also holds the position of Global Head of Quality Clinical Programs and Projects for Aga Khan. Karl Blanchet, who's a director at the Geneva Center of Humanitarian Studies and professor too at the University of Geneva, and Thomas Kergall, who's a senior technical advisor for Health and Social Care Council of Europe Development Bank. So I'm sure you'll see that hopefully we'll get you inspired into action and also have a dynamic conversation. So firstly, I'm going to just try and provide some framing and about why the health sector is so important to this agenda and vice versa. And actually, I feel as though the whole day has been building up to this, because everybody has given some fantastic examples as to why climate action can have a direct impact on people's health, but also why our health matters to the environment as well. And we've talked about healing people and healing the planet. We've also talked about the fact that the health sector is responsible for, over 4% of global emissions, and I think we've heard at least twice that it's more than the aviation sector. So it is, it is a big sector. And if you just pull in the pharmaceutical industry, it becomes even bigger. And it's also one of the most powerful levers of change. And I think that's what I'd like to inspire in you today, is some of that human aspect, which is about health matters to us all. It's part of who we are. We're all patients at some level, at some point. If you're lucky enough not to have been a patient yet, then congratulations, you're contributing to a better planet. But, at some point, there is something about we all have to face, how do we want our care to look if we want it to help us, and heal the planet? And that's not easy. It's not... there's a lot of unanswered questions, and I think from the examples we heard this morning, there were some fantastic descriptions of projects that work, of some things that don't work so well, and I think it's okay to not know all the answers. We just need to get started. That was another key message that came out today. So if we think about every decision that's made in healthcare or in health services, we know that it connects us as people, as patients, it connects us to the environment, and it also, which is a foundation for our health. You can't, if you can reduce air pollution, if you can, reduce climate impacts, you can actually reduce toxicity, you will improve people's health. And it also links to the economy, because the other thing that we don't often mention is that the health sector is, 10% of GDP globally. It goes up to 17% depending where you are. So it's a significant economic anchor in society and in countries. And of course, having said the amount of percentage of GDP, I would just like to clarify something that I'm sure you all know, is that the percentage of GDP costs, or the amount of money you put into healthcare, does not correlate with the best outcomes either. So it's not correlative, and we know that because, if you think of the US health system, that costs nearly double of most of what Western societies put into healthcare. We know, based on UHC indicators, that they are not delivering in any way better than other countries. So there's it's not just that if you pump money in, you're going to get better outcomes. So there's a real question about how do we look at it. And of course, the US health sector, not only does it cost a lot, but it's 25% of global health emissions globally. So there's some real questions to be asked. So the question isn't whether we should act or not. We all, I think, here today know that we should be acting, but it's about how can we transform the system to deliver better care within planetary boundaries. And we might want to call it a vision for green UHC, a green universal health coverage. And I guess I'm going to just try and say quickly, well, what do we mean by that, other than a shorthand of words that are convenient? But for me, and this is just my personal view, it's about better access to care. It's about better care within planetary boundaries. And that includes resilience and the right financial incentives, because at the moment some of the financial incentives drive the wrong answers, and we need to be clearer about that, because if we're going to truly transform this, we're going to need to align the incentives in the right way. So what might some of it mean in practice? We've heard a lot of the examples that have been said today, but I just want to bring one or two in. One is, food in hospitals. It's not just about reducing meat, but you can buy food locally, seasonal, drive the local economy, and really support changes in local practices in agriculture, drive better resilience. There are so many benefits there for people's health, for the local agricultural, for the economy. It's inevitably a win-win-win. And then the other one is, I think we heard about solar panels on primary healthcare centres in Africa and how it can drive changes. But I would like to also suggest that, with the fact that we're talking about adaptation and resilience, that we would want the community centres or the health centres to be the last building standing to support communities in times of crisis. And there was this wonderful example of the hospital in Bangladesh. But imagine a hospital that can also help power, phones for local communities that during a crisis can be used. So there's something about thinking through what this transformation could look like, so that healthcare and health institutions and health services can also be the bastion on which you can build human rights for people during these changes. So, and I'm sure we're going to touch on all of that. So just to get started then, I'm going to start with Valérie. And I know that you're a health professional, you've worked a lot in prevention, you've got a strong angle on resilience, but what do you think are the best levers to use to drive action and change amongst healthcare professionals?
Okay, thank you. Good morning. Good afternoon, Sonia. Everybody? Yeah, thank you. That's better. So starting with the WHO recommendation for each country to develop two roadmaps, one to decrease the environmental impact of the health system and the other one to adapt to climate change of the same health system. I think for the primary community care level, we really need to start rather with the adaptation part. So the reason is that if we entered immediately with the angle of mitigation, it's often beyond what they are able to do for several reasons. They have to apply clinical recommendation. If they have to give anti-cholesterol drug to every patient, even with low level, because an expert panel has, with some multinational also involved and saying, okay, the level will be very low. They cannot go beyond that. So here it's another level that has to change the guidelines. Also, they are already overloaded, so they cannot hire somebody like a hospital to take care of the environmental problem. And if they don't see a direct benefit on their daily practice, they will have no motivation to do changes. So if we start with their daily challenges, what are they right now and in the near future? First, they see an increase in the load of patients due to climate, due to older people, etc. And on the other hand, they see a decrease in the availability of resources, with shortage, disruption of medicines, of electricity, of many resources they need. And third, from time to time, they face a crisis when they cannot cope anymore, like the COVID crisis or energy crisis, other crises. So these are their daily challenges. And we can start there, and if we take care of not doing maladaptation, generally for most of the intervention we will have co-benefits for the patient, for the health worker, and for the infrastructure. So I will take two examples, one from the south and one from the north that we have tried to implement, so some health intervention. So in Tanzania, what we have, as in many countries, this increase in patients, while the human resource shortage becomes very strong. So to help with that, we have deployed some clinical decision support tools that initially were on paper, but nowadays are more on electronic material like tablets. And we have deployed that in many primary care facilities. And we thought, okay, maybe we are also doing some harm with bringing all this electronic material that we discharge after 2 years. We could kill lives while trying to save them. And I was really wondering if the health worker would be interested to think about that. And they were, not because of the CO2 emission, because obviously they are little anyway, but more because they knew that all this material in the soil, waste on the soil, would contaminate the place where they are growing their vegetables just after work. They go back home and they go directly to get the food they need. So they are very aware of that, and that was their main motivation. We calculated the impact. The electronic part increased the impact by 1.5, so it was not nothing, but the main impact was from the medicines prescribed. But here this program was also aimed at decreasing antibiotic prescription. So the impact was almost all compensated by the decrease of prescription, which is a benefit for the patient because they don't need that. And also health worker happy to do better quality care. The example from the north, there was an initiative to have green practices, but this basically failed in Switzerland. Because, I mean, they calculated their impact and then it was too much work and not much direct benefit. So we thought, okay, let's go through the energy crisis problem that we had in Switzerland in winter 2022. We interviewed physicians, nurses, told them a story about blackout, how would you be able to work during a blackout, to sensitize them on where do they use so much electricity. And they realized, one, for example, that had still paper-based patient file, that in fact he might be at the forefront with his strategy if there was a shortage in electricity. And obviously you immediately have the co-benefit of having less impact. Maladaptation is always at the corner. The home-based care network had already bought Starlink connection to have always internet in case, so that's an example of rather maladaptation. So based on this experience, we want to implement a new project on one territory in Switzerland with the Climate Action Accelerator to analyze local vulnerabilities, train health workers, and involve communities to really support these primary care facilities in case of a crisis, and to learn how to adapt to the big changes we will face.
Thank you so much. So a real message here about for health professionals playing into what matters to them, whether it's capacity shortages or something happening in their local home life that links in to their work life, and actually building around that a narrative that works for them is key. So thank you very much. So Zeenat, thank you for joining us. It's great to see you, and I know that you have been working on this. We had a wonderful presentation from Murtaz just earlier, so thank you for that. But I wonder how you feel that sustainability can be embedded into the core definition of quality of healthcare, because at the end of the day, it needs to be integrated if it's going to work. Question mark.
Absolutely. Thank you, Sonia, and thank you all for having me over. It's always a pleasure. My perspective is very similar to both the previous speakers, because at the end of the day, we are not isolated. Healthcare, hospitals, and I will specifically talk about health system, primary, tertiary, to all the way to tertiary and beyond. We are not in isolation. Whatever we do gets impacted, and whatever is happening beyond our boundaries is impacting us. And how in the last 10 years, hospitals were very isolated. We used to worry about patients come, we take care of them, they go away. But in the last 10 years, or in fact, much lesser than 10 years, I would think, at least in my Aga Khan Development Network system, since 2019, 2020 is when we really picked up what is this whole discussion about go green, and how do we improve ourselves as well to have positive impact. And we realize that what we do inside our health system is affecting outside, whether it's the outcomes of the community for maternal, whether it is the colleague talked about food, growing the food, or Sonia, you talked about buying of the food from local community, and so on and so forth. And it opened up our horizon. And as time passed by, I think this topic has to become part and parcel of the bigger governance, bigger regulatory standards, overall quality of care and quality of outcome of any hospital or healthcare system. You heard Murtaza earlier in the day that we are doing a lot of work, but that work is happening starting with our governance, our leadership, putting up quantitative aspects, making it part of overall quality. And in that one, I think quality regulations in countries where Aga Khan development works, such as Africa, Asia, Syria on the other side, and Afghanistan, we do not necessarily have very strong government regulations asking us to do mandatory aspects of quality of care or working on the carbon emission. But then there are standards such as safe care, such as Joint Commission, where we have seen that as quality standards, they have brought about carbon emission and impact aspects. How do you plan it? What are your measurements? What are your strategies? How are you monitoring them? And so on and so forth. So I think we all, and all of them must go down to the staff and the patients and our communities, which we have been talking about earlier. It is so important that we don't take it as an added burden on an institution. We have enough to work in our healthcare industry. But if we make that part and parcel of our operations as our outcome, as our quality, define it as our quality, impact, work with the pharmaceutical agencies outside, work with the local vendors outside, work with the fruit market vendors outside. I think if we do that in a systemic way, the impact is much more sustainable and long-term. involvement of the staff, I cannot speak more about the importance of that, and I'm sure Murtaza did. So many amazing aspects and strategies which can come through our staff who see this happening every day. So I think, Sonia, as healthcare system, as Aga Khan, at least our institution, and many other I have met in our International Hospital Federation, World Congress, or with various other forums, want to have adopted, are trying to ensure that carbon emission, go green, is not an external phenomena. It is part and parcel of our quality, our care, our standards, so it becomes a routine for us rather than somebody's imposing something upon us. So I think that's my view in terms of how do we inculcate into our operations standards and quality. Over to you, Sonia.
Thank you so much for that. That's a great illustration of how you can integrate things and try to reduce the burden as an extra element on everyone. So, Karl, this is going to be awful for me to say, but I think I see you a little bit as Mr. Resilience. So, what does it really mean in practice? Because there's so many different definitions as to what resilience is, and I hear the word used everywhere in different ways. And how can it be strengthened?
Thank you very much. So, first of all, I want to describe the ecosystem where I work, my context. So very much what I do. So I work a lot in armed conflict countries, humanitarian crises, and low-income countries. And my context is very much about underfunded health systems. Afghanistan, $7 per capita invested. I currently work in Afghanistan, in Yemen, in a few refugee camps in Jordan. So that's the kind of context where I work. My question is, how can we talk about climate change in this kind of context? Cut of international funding is not the right time to think about. You need to do additional investment. You need to do it differently and invest in some of the different solutions that have been expressed in the previous panel. War, as you can see every day, is a polluting factor as well. Okay, and now they want to bomb oil wells and so on. So that's going to be catastrophic. Water in Gaza have been polluted by the Israeli army. So here we are. That's the kind of context where I work, and still I'm talking about climate change when I talk to hospital managers and health systems and ministries of health. The problem I have, and we had briefly discussed, is the time horizon I have. But I have exactly the same difficulty, and even more, to talk about climate change than we talk about prevention. There's no investment in prevention. And every time it's all about, if you invest now, you're going to have some benefits in 10, 20, 30 years. Okay, some of them, as maybe Valérie is going to talk about that a bit later, can be much shorter. But that's a key issue for us. But still, and everybody is well convinced about that climate change is transformative. And that's going to transform the resilience of systems, of health systems. There's no alternative for it. So what do we mean by health system resilience? It is, first of all, it is about being performant. And performant is about making sure that the services have good quality. We heard that with Zeenat. Making sure that we cover the needs of the patients. Making sure that we've got the competent healthcare workers. Valérie talked about that. The right guidelines, the right quality of care guidelines, and so on. That's a plus. And we need to have resources, supply of drugs, and so on. But we need more than that. Health system resilience is all about the capacity to adapt, to absorb, to adapt, and to transform after a shock. And climate change is a kind of permanent shock that is currently happening. Sometimes it has even higher visible signs, flooding and so on, heat waves, but it is a permanent change. and the permanent shock, and this is going to be transformative. It is transformative for all health systems in the world. But what does that mean for people who manage these health systems? It does mean that they need to manage services and health systems in a very different way. It does mean that healthcare professionals need to have access to information to non-health sector experts on climate, forecasting. They need to plan in a different way. They need to anticipate the risk. They need to anticipate the solutions as well, and sometimes without and with healthcare workers. Sometimes these solutions or these data or this information, this knowledge can come from communities. So all these dimensions, and I will expand a bit more a bit later, but it does mean that the way of managing and governing health systems is going to completely change, and is going to be, with multi-faces and multi-sectoral, and there's no alternative for that. So that it's a very transformative change for us.
Thank you. I do have to ask you a follow-up question before I move to Thomas, because you've said something that surprises me, and I think I'm finding it a little bit shocking, because you're saying that climate change is going to drive this transformation to resilience. And I'm in this naive hope, actually, that it's us as the health systems that are going to change in order to better deal with it, ahead of it, maybe not, ahead of it, or not ahead of it, but because we want to address capacity issues, because we want to address better clinical care, because actually it's multifactorial, and it's not climate change that's driving it, it's the fact that health systems are not sustainable anyway. Even without climate change, they would be too costly now. We would be lacking in resources. We'd have all sorts of other issues. So I'm sorry to interrupt with that first counter question, but it's intriguing to me. Have you got a brief answer?
So, no, you're absolutely right in everything you said. But I think some of the countries, and Kenya, Tanzania are very good examples, but we hear as well from Pakistan and China, of course, are actually want to do better than that.
Yes.
They want to go beyond that. So equitable access is the key for many countries. Quality and equity are at the core of what people want to achieve. In every country where I go, Yemen, Afghanistan, they all talk about that. This is what they want to achieve. And now some of the countries are already saying, okay, can we go beyond? Because in 10 years, that's not going to be sustainable. We won't have this kind of energy, and power cuts is not sustainable anymore.
Yes, thank you. And I think it came out this morning that actually you can't, I think Roberta this morning actually said that she did not believe that you could tackle climate change without tackling equity first. So that's an interesting point that's come through again. Thomas, you're representing investments, financing, and we know people always say you need to watch where the money goes. So I was wondering if you could describe to us briefly how financing frameworks can enable high quality, low impact and resilient care at scale rather than hinder them.
Thank you, Sonia. So I don't want to disappoint you, but I work in a bank, so this is why I wear a suit. But I'm not a banker. This is why I don't wear a tie. I'm actually the only person specialized in health policy and public health at the bank. It's a small bank, the Bank of the Council of Europe. We're based in Paris, but we cover 43 countries. So I want to apologize because I'll have a bit of a European bias on the examples that I will give. But what I basically do is that I appraise and monitor the projects that we finance, and I do this for the health portfolio of the bank. So I'll try to focus indeed on the question you ask and basically what role does financing play in changing health systems. So I'm not going to talk about theory, but rather what actually changes when a hospital project is well prepared, well reviewed, and how we finance that. So I'll have 4 points, hopefully 4 minutes. My first point is really that financing can influence decisions early. And from a development bank perspective, I think financing comes into play at a very early stage, well before construction starts. And this is actually when choices are being made. They are being made about how the hospital or the health facility is going to be designed, how it will be using energy, how it will be dealing with heat, water, or power cuts, and how reliable it will be in difficult situations, in situations of crisis. So these, of course, you understand that these choices matter a lot later on, and this can be addressed at preparation, at appraisal, durant l'instruction of the project. And so we have that project cycle, and for us, the technicians within the bank, we sit on the 5th floor and the bankers are on the 2nd floor. So for us, the technicians, we are fighting to get involved as early as possible into the preparation, the shaping, the scope of the projects that are coming to us, that are submitted by our member states or by our borrowers. Because indeed, if we go and finance a project where the design is already done and they just have to tender for construction, we at the technical department were very sad, and I'm the first one crying at the end of the day. So these questions are really part of discussions, and if a project ignores energy use, heat stress, flooding, or long-term operating costs, then it raises concerns to us, to the technical guys on the 5th floor, and then so we'll go back to the borrower, to the client, to the beneficiary. So it can be the Ministry of Health, it can be the hospital management, and we'll ask those questions because this is really what matters to us. We are of course Paris aligned, like any other international financial institution, and so in a very implicit way, we will be looking how the financing framework can steer projects. I have only 1 minute, but I did only 1 point. I have 3 more points to go. So my second point is actually how to turn those good intentions, those good wishes into solid projects. And here I like to say how to actually make a project bankable, but bankable not in the way that the bank is going to be interested in, but in the way that it's going to be sustainable and we will be financing something that actually is in the long term bringing benefits. I forgot to tell you that CEB is the social bank of Europe, so we are really looking at how to reach out vulnerable population. And as you know, with climate change, the most affected by climate change are usually the most vulnerable populations. So what we will be looking is at whether the design requirements are fulfilled, because if they are not, then the project becomes meaningless. And this is why financing plays a big role in the appraisal. We will be looking how designers have to show how the building will cope with heat waves of heavy rain. We will be looking at energy systems that are locked at a more carefully, and backup solutions. I still want to give you a few examples of where we work.
Briefly.
But I can do this whenever you want in the next 60 minutes.
Thank you very much for that. That's great. Because I would like us to have a conversation. I would love to have some questions from the audience. I'd like to have questions online. And so while you're thinking up your questions, I'm going to ask the same question to all of you, but from your different perspectives, because we've been bringing in the sort of health professionals' perspective, the management and quality orientation, the sort of resilience on the ground, and how you make this work in very different circumstances, the financing aspect. But really, one of the things that interests us is how can we influence the ways of working at the different levels, because we've talked about bottom-up, we've talked about top-down today, there's also about how we incentivize the middle, but to really ensure that this is about transformation and not just little steps of incremental change. So I'm going to go to Zeenat first. You've just come up on screen, so I'm going to go to you first. But just a brief answer on that would be wonderful.
Can you hear me, Sonia?
Yes?
Sonia, in healthcare, we deal with lives. And we say that, every step, meaning better care, life-saving, better outcomes, quality of life, etc. For us, in healthcare provision, we got to take it as an outcome measure. We need to have governments, regulatory bodies, governance boards, making it mandatory. Yeah. How to do it can be dependent on institutions, but it has to be done. We measure our healthcare infections. We measure our mortalities. Government wants to know about PPHs or maternal mortalities, etc. We need to make these as mandatory requirements at different levels. I'm not saying we go in a way that we can't maintain it or we can't get to that level. But the regulatory bodies, governments, JCIA, Safecares, etc., we got to make some things mandatory. And then let the institution decide how to get there with their pace. We need to have some reimbursement attached to it. We know outcome-based reimbursement, DRG-based reimbursements. I think it's time that we also bring the global Go Green monitoring into reimbursements. So some strategic level aspects of governance, regulations need to be put in place for us to make it impactful and mandatory.
Thank you. So really integrating it into governance, but allowing the choice for professions, for organizations to do it the way that suits them best, because we talked again today about it needing to be localized. And I'm also retaining your financial incentives, and I've got an anecdote about that later. But Valérie, would you like to come in here? Because I know you might feel that top-down feels a bit harsh.
No, I think on the contrary.
On the contrary, okay. You like it?
No, I was just thinking one thing. You were bringing this point. Why can we not drive it all through the cost problem? We have a cost problem, at least in northern countries, also in the south. And this will lead automatically, let's say, to be ahead of the climate crisis. But at least in Switzerland, all decisions that are taken right now go exactly in the wrong direction. We are only accelerating costs in the health system. We do absolutely nothing on that. So the only thing that stops us is some crisis. That means a shortage in antibiotics. Suddenly we have the right to give it by pill rather than waste a third of the medicines. Or on the other hand, what studies have shown that if there is a shortage of medicine, for example, clinicians tend to, they say, I would like to do evidence-based medicine, less is more, smarter medicine, and only prescribe when necessary. But in fact, what they do is prescribe broader range antibiotics, so making the situation even worse. Yeah. So this shows that if you let individual people trying to deal with all these challenges with no governance at the top,
it doesn't. No. Okay. So you're up for governance, and actually, it's not just the cost agenda that's going to drive it, but we need a lot more. So
clear decisions. Yeah.
Karl?
I think it depends on when you're talking about. So my answer. Okay, but so if it's so I'm much more on the adaptation side of it, and in that case, when we need huge investment on cities or on infrastructure, yes, of course, the top-down approach will be necessary. When we talk about, for example, heat waves in Pakistan, there were quite a few beautiful programs, community-based programs, actually, where you have peer support organized. First, it was injected with an idea with one innovator, but then it was completely sustained by family members and peers. And so here we are. We're not talking about investment. We're talking about a response that does not require a lot of money, but requires actually personal investment. And this is what people do in many, many contexts.
So a community engagement and own personal investment in that. Thomas, what would be your answer? And then we'll open up for other questions.
To what part of the question?
So to the question, how can we influence ways of working to ensure change at different levels?
Right.
And
right.
I guess money is one driver?
Well, money is a big driver, but on the other hand, it really depends whether an investment bank like ours wants to get involved into policy making. And when it comes to CB, I think we're too small to pretend to have such an ambition. But still, I think the challenge for an investment bank is really to find a way to reconcile how to improve healthcare delivery and therefore integrate climate change dimension, mitigation measures and improvement in the delivery of care, whether it's about medicines, whether it's about management of waste, whether it's about discharging people earlier or sooner or later, whether it's about, I was talking to Pierre during lunch, incentivizing less invasive care, etc., etc. And the need for a bank to do business. You know, what I have to fight for every time on every project when they are being implemented is, are we going to disburse or not? Because if we don't disburse, we go bankrupt.
I'm going to ask Karl to come in, and then I'm going to go back to the room for questions, because I sense that it's tickled your interest.
I prepared a few figures for you. And so I was searching a lot on the cost-benefit analysis, because for governments, it's a huge, reason for investing, incentive, exactly, thank you. And we've got quite a lot of, and then I've got a question for Thomas. There's a lot of evidence that we have on air quality health index program, for example, in Hong Kong, and basically investing is going to bring, if you invest $1 today, you can get $3 back in 10 years. There's an example of the sponge cities in Wuhan, for example, in China, where you invest $1 today, you can have a return on investment of $5 in 15 years, because by reducing pollution, more groundwater for the city, and so on and so on. There's a Cool Roof program as well in Pakistan as well, where you can reduce hospitalization admissions. And again, you've got a lot of cost benefit in that. It is not immediate, but it's very much in the 10, 15 years. So if you invest now, you can have a lot of investment. It is estimated, and that's for Thomas now, that we need, today we invest around 20 billion between the banks, between bilateral aid in low and middle income countries. But only 15% of these resources are targeting resilience building activities. And I was just wondering whether you can see a changing trend among the banks, and whether or not this trend is going to change, because this investment is not good enough. And you think that's going to change, and on which basis?
And a brief answer, please, because I'd like to involve the audience.
I do, because you see, 10 years ago, there was no climate change specialist at the bank. There was only one person looking at environmental and social impact of our loans, of our projects. Since, so for the past 10 years, that person has been supplemented by 3 other people, looking at those issues, and a climate change specialist. We have now drafted safeguards that are fully part of our procedures and operational guidelines that are shared with our borrowers. So now the borrower has to take into account those dimensions. Maybe one thing that could be of interest, procurement. 6 months ago, we got approved by the Administrative Council the idea of sustainable procurement. And so now it's not an obligation, but when we go and appraise a project, when we go and give some advice to improve the quality of the project, to make it even more bankable, we strongly encourage that procurement is made in a sustainable way, and there is a definition from the European Commission on those aspects. So little by little, step by step, of course we are not going to ask the same thing in Belgrade than what we could have in Helsinki. But we are there, we are getting there.
Thank you. Valérie, I see you've got the microphone.
Just to say that the top-down was really for mitigation, for adaptation. That's really different. Here, I think really it has to come from the communities and the health workers. Yes. So this is really a different situation.
It's interesting because I really believe that we need to integrate mitigation and resilience building as one and the same action, and it needs to be done with communities for best impact anyway. But that's another conversation. Anybody in the room got a question, or anybody online got a question that you'd like to bring in? Because it's really, I can't actually see you very well. But if you put your hand up very high, then we can take note of you and bring you something. Otherwise, we've got plenty to talk about here anyway. Sonia.
Yes, I'll just quickly take it. Sonia from the Climate Action Accelerator. I have a question for Thomas. So thank you very much, and I find it's quite intriguing and fascinating, the work you're doing on, integrating the climate dimension into the finance. I'd like to get back on the policy question, because you talked about policy making, and maybe that's not your role, but isn't there a role for you to play on, influencing policy, sharing your experiences, maybe also influencing other banks and, trying to influence their practices? I would be interested in hearing more about that.
Thank you for the question. Indeed, I would say, when I say we don't do policy making, we are not the World Bank. So the World Bank is giving advice and, having health master plans at country level. We are not in a capacity to do this. But indeed, and this is actually the challenge I try to meet when I appraise those projects, is to bring some added value to the project. So it's typically bringing technical assistance, expertise, people who have the experience of bringing those dimensions into the projects that we would call in, and we would strongly encourage. Actually, there are different funds at European level to do this inside or outside the European Union. So it will really be about giving advice, bringing the expertise, comparing projects between the eastern part or the northern part of Europe. So there is definitely a role, and this is the added value that we can bring. Not only the good interest rate for the Minister of Finance that is actually borrowing on behalf of the Ministry of Health, but it's also this assistance we can bring. I always like to say that we work in North Macedonia, where there is one hospital built every 30 years, while we also work in Turkey, where you have 30 hospitals built every year. And in Turkey, they know more or less what to do. We finance a hospital in Kilis, which is on the northern side of the Syrian border, and with the earthquake, it was the only building that sustained. And we were very proud of that. But we also financed a hospital in Zadar, in Croatia, where everything was done to prevent flooding, and it was affected by floods, but not from the ground level, from the top, because the roof was not done properly, And so all of the building was underwater and totally not operational for more than a year.
Thank you so much. Any other questions? Because if not, there's a question over there. But let's just see if there's 2 or 3 questions and we can take them together. And then I'll return to my own questions.
Thank you so much for all of the interesting insights. Over lunch, I heard an example of collaborative funding solutions. And I'm wondering if, not only for the banker who's not a banker, but for all of you, whether you have other examples of collaborative funding and maybe innovative funding mechanisms.
Any other questions that are in the room that we can pick up at the same time? You're going to have to just shout because it's hard to see with the floodlights. At the back there's a question.
Yes, I just wanted to hear more about any preventative healthcare measures and why nothing is being done more in that space, as it has an impact on both sustainability and the financial aspect of the healthcare system.
Prevention of ill health.
Yes, and especially in chronic diseases as well.
Thank you so much. Any other questions? If not, let's answer the collaborative financing question, and maybe we could start with Karl. Have you got examples? No? Then Thomas?
Yes, everything that we do is collaborative.
With communities or with other partners?
With other partners. Why? Because we never finance a project 100%. So we always have a partner. Either it's the ministry, the country, or the borrower that does finance part of the project as well, or it's another IFI, another institution. We work a lot in Europe with the EIB, the European Investment Bank based in Luxembourg, and so we are more, I would say more or less, no, we are 99% aligned on everything that is related to climate mitigation, prevention, and improvement of infrastructure. When it comes to innovative solutions, these are always tricky because behind a loan you always have a guarantee. And when it comes to the guarantee with innovative financing, then it becomes more complicated. And as you rightly said, I'm not a banker, so I won't enter into that topic.
Thank you, Valérie.
Maybe a practical example, in Switzerland and France and other countries, there are many initiatives from health workers to open new maisons de santé, community health center, to increase equity, to do medicine in a more sensible way, etc. So generally they start with finding money from local donors who are interested because it's innovative, but after 1 or 2 years, generally they stop giving because it's not new anymore. So then we have one small in north of Lausanne like that also. So after a while we say, okay, we need something more sustainable. So sometimes local authorities suddenly get interested by this initiative because, maybe it might decrease hospitalization, we can save a bit of money. So you are going back to the public system, which is, I think, good. Yeah. If they don't change rules all the time, and there are 10 of these initiatives in France, and now they are threatened because the government suddenly decided to change the rule and to stop the support from one day to the other. So the last possibility, we have that in Lausanne, is asking people to pay a bit directly, 5 Swiss francs. This can help a bit, but cannot cover all the costs.
Thank you very much. And another reason why governance is so important. Zeenat, do you want to come in on the prevention side? Because I'm sure that you would want to reduce hospitalizations, make sure people don't get ill in the first place.
Absolutely. And there is so much work happening in the communities. At least I can speak of Kenya and Tanzania with our network, where we are working with it. And again, I go back to working with public sector. It's so important that we work with our partners, private, public, and bankers and banks and grant funding available to get to the communities and look at the prevention and promotion. I can give you an example, cervical cancer. And looking at it in Kenya, we are calling it as East Africa Cancer Care Program for Women. And we are going to girls in school as healthcare institutions and working with them on HPV vaccinations, good practice, nutrition, health, outdoors, getting away from screens, etc., to talk about prevention and promotion and cervical cancer and cancer prevention. And all of these are ultimately something which is long-term, have yield to have more financially sustainable. Prevention is cheaper than cure, is what we keep saying, that let us work towards it, and that's what we are very much very in tune with and work around.
Thank you very much. So I'm going to ask you a difficult question, Zeenat, but it's going to apply to everyone. This morning we talked... Sorry, you can, of course, please.
So prevention, and I give another example on surveillance systems. So on infectious disease surveillance systems, we know that it's all about making sure that you identify patient in a timely way, and as well that you refer the patient who needs to be referred and not the wrong patient, because that's very, very expensive for the system. We know that if you have a proper surveillance system, if you invest $1, you've got $7 of return on investment immediately. Okay, it's not even 10 years. We know that during the crisis. The second aspect is that this is what system resilience is about. That more and more in many countries, because the central level is failing, a lot of initiatives are initiated by communities, and a lot of community-based surveillance systems. And I think this is what the crisis and the climate change is going to teach us, is that a lot of risk or shocks that are going to affect the systems are unpredictable. And how to be flexible and agile enough to respond to that, you need to be decentralized. You need to decentralize power and decisions, and making sure that people on the ground who are affected directly by the crisis can make the right decisions at the right time. And that's very important in this new governance system.
Thank you very much. I'm going to ask you all a question because it relates exactly to this, is that what are the measures that we should be adopting other than carbon reduction? We had a wonderful presentation of how bad the climate is getting, the observable facts, the symptoms that things are getting worse. But in a way, we're not matching them with health outcomes or with mortality. And one of the issues that was raised was that it's more difficult to calculate, and maybe with prevention, it's difficult to calculate what's not an admission, what's not a something else. So what do you think should be our measurements so that we can take these things into account? You've just mentioned a return on investment as a very direct, palpable one. But are there other ones that we could use that would actually help drive our indicators if we were to be able to feed this into our governance?
Okay, so I've got concrete examples coming from Afghanistan. So challenging environment this year. And they realize that their hospitals are completely overloaded. So I think, Zina, you know that I work with Aga Khan Health Services in Afghanistan. So you've got regional hospitals where you've got too many patients, and they have the wrong ones. So you've got a system that relies on hospitals very, very expensively, where the health system is underfunded. So now the decision from the ministry is to reinvest on primary healthcare and making sure that there is a kind of gatekeeping system in place, and making sure that actually people who are going to be referred to the next level are going to be the right patients. And that's important because that's going to not only improve the health outcomes, the timeliness of being managed by a professional is going to be much shorter. So all these indicators are going to be very, very good. The second aspect in the system is that people are going to learn to work together. They're going to be interconnected. They're not going to work as simple health centers working next to district hospitals. They will have to collaborate, share data, share patients, feedback, and so on. And that's very important. And this is what resilience is about. And this is how people are going to be better equipped to actually manage unpredictability and this kind of volatility that we have currently in the system.
Thank you very much. Zeenat, I saw you nodding and with the sort of different things that matter as well as the environmental impacts.
Yeah, I'm very honored to be part of a system where we have a university with us, Aga Khan University, and our researchers are amazing, who are really based in the population health and talk about this issue with outcomes. And I'll tell you what, disease incident rates is something, the tracking of increased asthma, allergies, infections, cancer. Some of them is very much related to our environment, which we can actually monitor and justify or work towards it. Disability adjusted life years, daily as we call it, and I was looking at one of the studies in Pakistan which is being done, which is about maternal outcomes, stunting, newborn outcomes related to carbon related outcomes. So, our life expectancy decline, I mean, it's causative and perhaps have many other aspects. But yes, it is doable. It can be too big, but if we want to funnel them and come up with some core measurements of how does our health outcomes are affected by high carbon emissions, etc., is definitely a lot of good work is happening in the medical research.
Thank you. Valérie, I feel you've got...
Yeah, just an experience from Tanzania where we collect this real-time clinical data through our clinical decision support system in the health facilities. So we can see exactly when diarrhea goes up, goes down, malaria, etc. And we try to make links with meteorological indicators. For malaria, we easily can do that. This is well known. So the idea would be to have indicators to the district level that when they see a drought, they know that behind there will be this and this probability of having some outbreaks. It works less for other diseases than malaria because there are so many other factors. And in fact, the impact of a drought is not direct on patient, is through the lack of food. So this we have to always to keep in mind that these other big confounders are really important. So could we help authorities to take decisions? I know some countries, they know exactly that when they have flooding, 2 weeks later they have a leptospirosis outbreak. So they know now, because it happens each time, so they prepare, they know, okay, we will have to deal with leptospirosis cases. So people are learning while doing, but this is a bit in the crisis phase. For the more long-term impact, this is difficult to measure because it's often chronic disease that we see anyway, so it's just the load of patient that is increasing. And what is the attributable part to the climate, for example, is not easy to assess.
Thank you, but it's back to the prevention question, isn't it? Karl?
I've got, I'm working, so I'm on this document because I'm working on a draft document, and there are 20 indicators for you if you're interested. But I give you some examples. Organizational flexibility, supply chain diversification, not relying on only one supplier, leadership decision-making speed. It's all about flexibility. The previous session is all about infrastructure. We've got plenty of indicators on that side. There's something about time to implement new protocols. It's all about making sure that actually all these heavy centralized systems are going to disappear. So the bureaucratic systems have to disappear in many, many health systems. That's going to be hard, but local actors, they do understand that. And they find ways of going faster because they need to respond to a shock or a crisis, and they do it.
Yeah, thank you very much. I mean, so we've talked quite a bit now about adaptation and resilience and indicators that are linked to health outcomes. And I guess my question, and we're going to be moving into a sort of different part of this panel, is Bruno spoke today about what makes an organization fit for purpose. So how do we make them low carbon and resilient and equitable? So how do you see us bringing together indicators, governance, financing, and health professionals to make that happen? I'll start with Thomas. Do you want to start? Or?
Of course, I'm happy to start, because it always comes back to the same issue on my side, which is really how well prepared is a project. It's often very difficult to make the politician who is behind the decision-making on building a healthcare infrastructure, to make them understand that the more years they spend on preparing the project, the less years they will have to spend on building the infrastructure. And preparing the project is also about the flexibility. After COVID, it is obvious that you need to make sure that you are able to render your infrastructure flexible to increase the number of beds or get separate entrances for people who are affected. But it's also about making sure that the health professionals are associated to the master planning of the hospital in the beginning. What I have to fight for all the time is that the hospital construction projects are procured by procurement people. They're not procured by people who know about healthcare. And so then you find yourself with functional planning, human resources planning that are not done the proper way, equipment that comes too late, or equipment that comes too early that sits and then gets rotten. So all of those aspects, again, if it is well prepared, if the borrower who we can't blame them, has no experience in a construction project, then it's much easier.
So your dream wish to make that happen?
It's not only a dream. I mean, we do make that happen if we have in front of us people who are ready to listen. And here I will not give examples of people who do not listen in Europe. But you can imagine that the countries where and so it comes back to governance. The countries where there is a possibility to debate is stronger are the countries where you can actually spend more time preparing projects. Those countries who keep things secret, those countries who have, because it didn't happen otherwise, only one tenderer to build a hospital, even though everything was procured the right way, are not those countries where there will be the most advanced dialogue between all the communities that are involved into the construction process. And by the way, when I say communities, part of the questions that we ask at appraisal is whether the local community is involved into the not the construction project, but the impact that the construction will have on the neighborhood. And of course, if you have people who need to be moved out, if you have acquisition of land where people live, then this becomes a big issue for us, because as a public investment bank involved in the financing, the last thing we want to see is that our name is associated in the press with the fact that 2,000 people were kicked out and not compensated properly.
Thank you very much. That's a good example. Zeenat, do you want to come in here with what do you think makes, what is needed to make an organisation fit for purpose? I know you feel that Aga Khan is fit for purpose already.
Not at all. We are nowhere close to it.
Okay.
We are doing very well and on the right track, but we have a long way to go as well. You know, Sonia, I agree. I think planning is so important in what do we want to achieve, what are our steps to do that, and why are we doing various steps which we want to take. But I think implementation is equally important, and because as Aga Khan in the developing countries, we might have fantastic plan, and we have involved international planners and consultants and come up with a great planning. Execution plays an extremely important role as well, and I think that's where the role of the governance, the steering committee, people who can keep us on the right path and making sure that we are monitoring all milestones as per the project or the plan, I think is equally important, and we really face challenges. We do, and that's a real example for us. Our planning is very well, but execution on the ground and the risk related to that, I think we need to work on that in our planning, and also as we go along, that is monitored in a very strong way. So implementation, execution, and its monitoring needs to go hand in hand as well.
Thank you. Valérie, do you want to add to that?
Yeah, an example is the Canton de Vaud, where I live in Lausanne, where after the COVID crisis and the energy crisis of 2022, the authorities said, okay, now we have to get prepared. So we list all the risks. They came up with 37. They reduced them to 12, and then they went to all, not only health, all infrastructure, and they spotted, okay, you will help, you have to have a plan, etc. So this is high-level institutions, like Unisanté in Lausanne, for example. But then when they had to go down, they sent some letters, some SOP, and the people on the ground said they are not applicable. Rubbish bin directly. So from there, the authorities said, okay, what do we do? And they said, okay, you do it on your own, because it seems we cannot help you, so you have to organize yourself. But then the problem starts with people not being even aware that there are this risk. So that's where we came with sensitization. So we really took an actor, a theater actor, who plays a situation and tried to emerge people, health workers, and realize that this could really happen. I mean, this is very different from the South, where they know exactly this happens all the time, and they have plan B, but in the North, I mean, this is the first step. And from there, you can start working with people and provide solution. And for now, what we do is the top-down is trying to do something. We hope from the ground also, and one day, hopefully, we will meet. But that's a long time forward, I think, still.
Thank you very much, Karl.
Thank you. Yeah.
So what would you think makes an organisation fit for purpose in this sense? And that where I'm trying to lead to with this conversation is that we've been talking a lot about health, why acting on health helps the climate, but also why acting on climate helps health. But is any of this that we've been talking about applicable to other sectors for people who don't care about health?
Yeah, no, absolutely. I mean, when we talk about resilience of systems, we can have the same conversation. I'm sure people working in transport, on supply chain, they exactly have the same conversations. And whatever the goods are on supply chain, not only drugs. We have defined 4 dimensions to manage resilience. The first one is about knowledge. And it does mean that anybody involved in the system who is supposed to make decisions needs to have access to the right information at the right time to make the right decisions. This information can be data, can be evidence, can be anecdotes of someone coming to Valérie, coming to me and say, look, there's a risk, you're not aware of this risk. Sensitization, for example, that's the type of information. It does mean that we need to have a social capital and then people are connected. The second dimension is about being aware of interdependence, in a sense that in the health sector, transport, whatever, or home office in terms of prevention of road traffic accident, for example, that we need to be aware that an action from myself or from my group or from my team is going to have an effect somewhere within the hospital or outside the hospital and so on. And of course, economy, finance, all of that is going to have an effect on me. The third dimension is about managing unpredictability. It's the idea of flexibility we talked about earlier on how to adapt quickly and having the creativity, but as well the decision power to make this kind of decision. And the last one we haven't talked much about is legitimacy. It's about every time you make a decision, your decision needs to be well accepted and needs to be contextually adapted to where you work. It does require co-design, consultations with committee members, users, patients, families, and so on. So that's important as well. So, and to me, these are the four qualities you need to have within an organization. Organization can be a small health center, a big hospital, or a national health system.
Thank you. And those four dimensions, which I love, I guess you would agree that they are applicable not just to resilience, they're also applicable to reducing environmental impact, tackling social injustice, and actually running a quality outfit.
Absolutely. And this framework does not come from health. We learn a lot from ecology and environmental studies, and we have adapted some of the framework they have used to the health system.
Great. Thank you. I love the fact that it's come from elsewhere. So do we think there's things that we've been talking about in health that could be used in other sectors? Valérie? Ooh, is that difficult, Thomas? Your bank deals with a lot of other sectors.
Exactly. So it's not that we think, but it's the case. Okay. And in fact, I'm standing here in front of you as the technical advisor for health at the bank, but I'm actually working hand in hand with technical advisors specialized in health, in climate change, I mean. And when we do the appraisal, we do the appraisal together. So they look at all those issues, not only for the healthcare sector, but for the other social sectors that we deal with at the bank: education, judicial infrastructure, meaning prisons, social housing, disaster mitigation projects, etc., etc. So it's really all across. And in fact, sometimes I work more with the bankers on the second floor than with my neighbor who is working on social housing or on education. But when he or she talks about the challenges of his or her sector, actually they are very similar to the health sector. Except we must recognize that in the health sector it's much more complex.
Of course. It's interesting because I think if you look at the UNFCCC, they've got roadmaps for transport, they've got roadmaps for, we've got a roadmap for humanitarian sector, there's a roadmap of sorts for healthcare, but in a way it takes us sometimes down a wrong way of thinking, because actually it's the collateral, cross pathways things that will make the real difference. So we're coming to the end of our session, and I've got an extra question for you, Karl, because you're Geneva-based, and there's been a lot of discussion today about whether International Geneva as an entity can contribute to this discussion within healthcare, within other sectors. Is there enough of a base for that to be demonstrable in Geneva? And then we'll do a last round. Yeah.
I mean, Climate Accelerator, I'm sure you're frustrated with the International Geneva, as we are. There's not much progress, there's not many policies. You have more and more interest in climate change issues at WHO, at the UN. Not much from MSF, for example, if I'm not mistaken. Nothing from RCRC. I don't know if someone from RCRC. Nothing. So there's not enough. And I do not know, and I can't explain why there's little appetite or little interest to invest in the sector. Maybe the complexity of the question might explain. We also see a lot of silos. You've got a lot of agencies, weather agency, UN agency on weather. It's very hard to make everybody work together. Having WHO, UN weather agency in the same room is very complicated. Our data sets are all in different places. There's no cross-analysis at the moment. So here we are. And our challenge as researchers is to cross-analyze everything, to forecast movement of population due to weather change and so on. Unfortunately, it's very hard to get access to data. And we can do it now. We've got the capacity to do it. So it's slightly frustrating in this current environment. But
I'm sure the people from MSF and ICRC and IFRC in the room would love to add to all the work that's being done, because I know you've been doing lots and lots of work. But I guess you're talking about not just within an organization, but how it feeds into a wider conversation at an international Geneva level.
Absolutely, and the IFRC is a counter-example. They have a department and agency working on that. We collaborate with them on different data sets and so on. So that's a very fantastic example of how the Red Cross movement has actually, and the national societies, I think, are much more aware because they are the victims of all the changes. So they probably push from the bottom to IFRC and say, look, we need some expertise now. So can you mobilize researchers and other people to come and help on different issues?
Thank you. We've done a huge tour d'horizon, as one might say, today. Did you want to say something, Bruno? You're very welcome to ask a question, Bruno. Here.
Yeah, sorry. It's a question which is not related to the previous one, but I feel maybe it's maybe a missing angle in the conversation. Is how far do you think that medical insurance systems, social security systems, or insurances can be a strategic ally in the climate transformation of health services, health systems? You talked, Valérie, about distribution of medicine, where we are in a situation where you were saying for outpatients, sometimes a third of the drugs are just wasted. And this is structural, is systemic. How long is it acceptable, still acceptable in today's situation? We talked about prevention, all the gains that can come from supporting more prevention in the health system. There are many other aspects. So if we want to have, it's difficult to have deep transformation without allies who have an interest in the transformation. And should they not be natural counterparts, allies, and do we not need to engage them more forcefully?
Thank you. So I'm going to ask you to respond to Bruno's question as your final closing round, and in a way, it'll be fit for purpose. Your words, Bruno. In that, I'm going to ask you each to say what do you think is going to help accelerate action, but also what do you think might be some of the main levers or partners as part of that. So, Valérie, you've got the microphone, so go for
just
it.
Regarding the health insurance, I think it all depends the setting, because if the rule, like in Switzerland, is that every actor in the health system has to make more money to earn more and be sustainable through that way, you can put any health insurance in the game. It does not change much. And the examples right now in Switzerland that work better is not really the one led by health insurance. It's more led by Geneva health authorities supporting some initiatives. So it's not automatic.
I think insurances generally around the world in healthcare could include in their requirements of hospitals the standards that Joint Commission International or Safe Care are putting in. And I think from that perspective it could happen. And we do have an example of one healthcare system that is both an insurer and a provider, and they have a lot less bed requirements because they're both. And that is really, really interesting as a different economic model. Sorry.
If health workers are fully involved in the decision. Yes. Otherwise, because
doesn't work.
From outside, it's difficult to know what will really work.
Yes.
But it's the final word right now.
Yes,
yeah.
Please tell us what you think will accelerate action and what maybe is the best lever for it.
No, I mean, from the community's point of view, I think in the South, what communities need is means. Because solidarity is there, they are used to work together, they are used to crises, to many problems. So here they really need access to tools, means, organization also. In the north, and now when I say north-south, it can be also urban, rural, because we saw in Switzerland that rural areas, we thought it would be more difficult because remote, etc. In fact, no, there is, everybody knows each other. In the anonymous towns, it's more difficult, and here you have to reconstruct the link between the neighbors, between the local health facility and people living around, because we have lost that. So we have to recreate that before we can do anything.
Thank you so much. It looks like, Zeenat, that you'll be the last one because we're going in a very linear fashion here. But Karl, go for it.
Okay. I think some of the best allies are, so Thomas, you need to give some money for that, the banks. The development banks are actually very interesting. So, and the insurance companies, I can come back to it as well. I think you're absolutely right. The banks, there's a huge movement within the bank, reflections on how to integrate climate change in every activity they have, in every investment. So I'm in contact with the French development banks, but the World Bank as well, and so on, and your bank. And I think it's a collective movement that is happening. So that's very promising. Insurance companies as well, they're looking for indicators to actually invest. And a few countries, Ethiopia, Eritrea as well, have been testing the system of insurance companies. So that's interesting. So what could accelerate? I think the example of HUG, for example, this afternoon, I mean, promoting good examples, good models, and demonstrating that, I mean, hearing from HUG, for example, on the benefits they have at different levels, satisfaction from the staff, from patients, economic costs, and so on, that's very interesting. But as well, my dream is making sure that every manager who is managing resilience can have a dashboard in front of them. And you're right, they need to measure the improvement or the progress they make every time they make a decision on timeliness for referral or patient satisfaction, financial issues, and so on and so on. And that would be my dream. So I'm trying to build this dashboard, this set of indexes that people could use, and they could ideally and in real time figure out where they are in terms of resilience. That would be fantastic. So accelerating, to me, make visible this kind of progress and the benefits on investing in this kind of issues.
Right, so climate in all policies, climate in all decisions, climate in all dashboards. Yeah. Thomas.
Look, I think I said earlier that CEB is not a climate bank. EIB in Luxembourg is the climate bank, but we are the social bank. But climate is a priority for us because, as I mentioned, I think as well, again, what we are trying to do is to support the most vulnerable, and these are the most affected by climate change. What I see today is a challenge in prioritization. After the start of the war of aggression of Russia against Ukraine, defense became the big thing, when climate was the big thing before. And so everybody in Europe started to wonder, shall we do more for defense and less for healthcare? Shall we do more for defense and less for social projects? Shall we do more for defense and less for climate change? I was talking with Pierre at lunch, who was telling me that Stellantis is giving up on electrical cars. Not because of defense, but actually they may be involved in producing in the defense industry. For me, this is not the choice to be made, because as you said, Karl, the issue is really about resilience. So we as a social bank, the big question for us is whether we should be financing defense projects. Of course, we won't be allowed to do this by our administrative council. But a good way for us to contribute is actually to finance dual-purpose hospitals. And those dual-purpose hospitals will not only be dual-for-purpose in case of a conflict, but also in case of a natural disaster, or a climate-related crisis. And so I think this is really the way we have to think of where to put the money. We don't give money, we lend. So it's always the people of the country that are actually paying for their infrastructure. We only facilitate in the lending. And last but not least, and because I think we had mentioned that we would say maybe one word about it, you mentioned AFD, you mentioned the World Bank. All of those institutions are part of a platform that is called FIX. I don't remember what FIX stands for, actually. But within that platform, you have a coalition of banks that are really trying to collaborate, address those questions of climate change, and see how best they could work together to meet those challenges.
Great. So collaboration and flexibility is what I'm hearing there. So Zeenat, you've got the final word.
And I would like to say that let us not make the perfection the enemy of good. We got to start now, and know where we are going. We will never be perfect. It's a new science. We are all learning together. Let us work together as a team, learn from each other, and move forward. And I think that's what I will tell my CEO colleagues if they are sitting around the table, to let us move together and onwards and upwards.
Thank you very much. And I love your point about learning, because we do need to be allowed to make mistakes, learn, adjust, and keep evolving. So I'd like to, can you please help me to thank all our wonderful panelists. Thank you so much, and I just wanted to thank both Kiran Jobanputra and Alex for all the support in coordinating this session, and also to the Geneva Health Forum and the Future of Hospitals and Health Systems for being a part in the background of everything that's been going on this afternoon. So thank you very much, and we've got the next part of the day, so thank you.